Good morning. I am Ananta Padmanabhan. I will be chairing this session. I think we are already late by a few minutes, but yet we will try to keep up to the time. The presentation will be for about 10 minutes. Then you will have time for question and answer sessions for about 2 minutes. And without losing much time, let me now request Kamalini Ramadas, who is the professor of management operations at the London Business School, a very prestigious institution, and she will speak about innovation in healthcare. May I request Kamalini to make her first presentation, please?
Thank you so much. I'd like to first say that I'm very happy to be over here, and I'm going to be talking about how IT is enabling innovation in healthcare today. What I'd like to do is actually to start with sharing with you three quite widely held beliefs about innovation, and then show you how these are being broken by what's happening, starting to happen in healthcare. So first of all, I love to ask executives what they think are the biggest innovations in all time. And when I ask healthcare executives or doctors or nurses what they think are the biggest innovations in healthcare, these are the kinds of responses I get. So things like cardiac catheter, Jaipur foot, vaccination, etc. If you look at these are all product innovations or science innovations. There's nothing here about delivery or services. People tend to still think that the biggest innovations are product innovations. Also, it's quite widely believed that you can either get very high quality at high cost, or you can get low quality at low cost. So people believe that there's a trade-off between cost and quality. The third widely held belief, some of you may recognize this, is Kevin Costner in The Field of Dreams, who said, if we build it, they will come. Or Emerson, who said, if you build a better mousetrap, the world will beat a path to your door. So the idea is that you build something and people are going to come to you. So I would like to now share some innovations that are actually shattering these beliefs. This one is a cardiac preventive care clinic for women at the University of Virginia Hospital that I'm involved with. And Dr. Amy Tucker, who is one of the doctors at this clinic, a few years ago decided to go from the traditional delivery method, which was one-on-one, half-hour appointment with each patient, to a group delivery method where they bring in about 6 to 12 patients at each time for an hour and a half. And there's no new medical science being practiced in this clinic. However, costs have gone down and outcomes are better. I'll talk more about that. And I just want to share a little bit about how ICT is enabling this operation. So they actually developed a homegrown IT dashboard where they have a combination of drop-down menus and customizable fields, so that when the patients come to the group clinic, at the end of the clinic, their clinic note is printed out and they verify it and they can take it home with them. And the interesting thing, I think many of you who are doctors have had plenty of education and learned all kinds of things in your lives. The nice thing about this is that the doctor doesn't need to learn how to type. There's a documenter who actually types in the clinic note while the doctor is seeing patients. And it's interesting that the doctor actually sees each patient one-on-one, so prescribing and diagnosing for each patient. The difference is that you have 10 or 12 other patients watching while this is going on. So as far as how this is affecting outcomes, we have what we're seeing is that clinical outcomes are quite comparable. So things like glucose and cholesterol and all of that is quite comparable to a traditional cardiac preventive care clinic. And on the other hand, lifestyle outcomes like body mass index are significantly better. Customer satisfaction is significantly higher. And also operationally, the capacity is greater, and so you have much faster response times and also much higher efficiency. So if you look at the provider efficiency for first-time appointments, it is gone up by about 250%, essentially because instead of seeing 3 patients in an hour and a half, you can now see 6 to 12 patients, say, in an hour and a half. And access has also greatly increased. So this kind of system basically clears the system in terms of the backlog of waiting for appointments and waiting for second appointments. And in terms of profitability, it's interesting that Dr. Tucker applied and received a grant for $3 million in 2008 for this clinic. I'm one of the PIs on that grant, and the deliverable for the grant was that the clinic needed to turn a profit in 3 years, and it has already done so, and it is quite profitable. And there is an unpublished study about the performance of this clinic, which is being developed. I want to share some other examples as well. So this is Cleveland Clinic's business intelligence system. So they developed this system in-house, and essentially what it does is it is a way of using IT to drive improvements in different parts of the business, and they have a short cycle dashboard, an OR dashboard, continuous improvement dashboard, and patient access dashboard. So I'll just show you some of these. So the short cycle dashboard, the idea is to very, very quickly give feedback to people on the floor, so nurses and doctors on the floor, to correct situations where some kind of problem might have occurred. So for example, patients in a cardiac institute coming out of an ICU who need to have a pneumonia vaccine. This chart here shows shows a comparison across different institutes within the Cleveland Clinic of this particular vaccine, whether it was given or not. And if the vaccine was not given, and you might wonder how come a vaccine would not be given, but for instance, if a nurse were to come to the patient to give the vaccine and the patient is asleep, then the nurse might not give the vaccine. So this application will remind the nurse, the specific nurse for the specific patient within half an hour, so that that error can be corrected. And this is what has happened to the adherence to this vaccination results. And as you can see, this is not any kind of new product or new science, and it is also pretty cost effective, not a very expensive way of correcting this problem. They also have their patient access dashboard has essentially created a way to look at all of the doctor scheduling data in a nice sort of overview kind of way, which allows the scheduling to get more out of the capacity that there is in the system. And they actually were able to add 100,000 slots in a couple of months of using the system with no additional physicians. And so again, I mean, there's no new products over here, and efficient use of resources. Another example here, I won't talk about this too much because I think Apollo and others in India are doing a lot in telemedicine, but I do want to say that telemedicine does have the potential to create very high quality at low cost, and it also totally changes the location of delivery of the service, and it isn't really a product or a medical science innovation. So what we're seeing with these types of delivery innovations is that this whole trade-off between cost and quality is really being broken, or it has the potential to be broken. And in the future, hopefully we will see a situation where no matter where the customer or the patient is located, they will be able to get very high quality delivery of different products and services. But I have to say that the thing that I find most interesting about some of these newer delivery innovations is that many of them actually change the boundary of the service that's being offered. So if you think back to this doctor's office at the University of Virginia, the Club Red clinic, the whole support group function, which traditionally is something that would be done by a third party, Weight Watchers Anonymous or any of those, has been taken into the doctor's office. And on the other hand, if you look at telemedicine, then the job of going to the doctor's office is taken over by the hospital. So there's this change in the boundary of what the service provider actually provides. And just want to share here a framework that Elizabeth Teisberg and Dr. Amy Tucker and I have developed to think about these kinds of innovation in delivery. So you can either have the service product itself, which in healthcare is, the diagnosis and prescription and drugs and procedures, etc., being innovated, or different forms of delivery, whether it's the nature of how you interact with your patients, whether it's the boundary of the healthcare service being provided, how the service is organized, or the location of the service. And technology actually plays a key role. IT, communication technology plays a key role in these innovations, but it's not just technology on its own. It's got to be IT combined with customer insight, understanding really what the patient needs, and also managing the workforce and the skill levels, etc., so that this whole thing works out beneficially. So essentially, innovation in delivery has the potential to create essentially new bottles for old wine. And IT is like the bridge which can enable this to happen. And what you can have happen if this is done well is a double impact on value, because it is both cost reduction and at the same time outcomes improvement. So I'd like to stop over here, and I'd love to hear any questions or thoughts about this.
Questions? Maybe we should have the questions at the end, because we have lost some time, so may I request? Next we have Professor Ravi Anupandi. He is the professor from the Michigan University, and he's also the visiting scholar to ISP Hyderabad. He is going to talk to us on the need to take a holistic and multi-stakeholder perspective in the use of technology for healthcare delivery.
Good morning. I would like to thank the organizers for giving me the opportunity to be here and share some thoughts on the value chain for healthcare delivery, and particularly the role of technology in that space. Before I start off, let me just give a brief introduction to what my interests are. My primary expertise is in the area of supply chain management. So one would think, what am I doing in healthcare? My current interest is in healthcare product and service delivery. I've done some field study of telemedicine systems in India in 2007, and currently engaged in several projects which include models of TB treatment, service delivery architecture for primary care, supply chain of vaccines, and from a demand generation perspective, social mobilization efforts for demand creation, because you can do this much to improve supply, but if there is no, there's nothing done on demand uptake, there'll be a mismatch there. For this talk, my take here is not necessarily IT, but more broadly technology in general, and with a specific focus on meeting the needs of underserved populations. So my focus is not really large hospital networks in terms of what they are doing with technology and IT, right? So if you think in terms of technology in that space, last decade was, I would say, the decade of telemedicine. There was a lot of talk about telemedicine, and this decade has started off with a big bang on mHealth. And the basic premise of both these technologies simply is that if the patient cannot come to the doctor, let us bring the doctor to the patient. And in the mobile case, maybe put it in his or her hand, right? If you scan the horizon, there are some great innovations, a few successful pilots, but sustainability and scalability remains elusive. So if you start thinking about, there is a lot of prior research in the business schools about the business value of IT in the non-healthcare sector. There are plenty of frameworks developed. Some of that can still be applied to the context of hospital-based IT systems. But the broad themes that come out of this is, why are we doing technology investment? Well, you do it to achieve one of two things. There is a strategic perspective, which means this technology investment allows me to be able to do different things that I couldn't do before. Or it is leveraged for operational excellence, which means you're able to do things differently and hopefully better and more efficiently. Now, from an applicability domain, you can think of, is the technology being applied to improve the internal value chain, which is, for example, technology systems for the hospital network, or it is being applied in the external value chain, which means connecting your suppliers or your customers in the external value chain, and potentially could include the patient himself or herself. Now, with that kind of framing in mind, what is the value in technology deployment? Most of the emphasis in my mind, this is going beyond IT, of deployment of technology has been more from a clinical perspective. Is it clinically feasible? Is it clinically effective? And largely continues to this day, maybe with expanding scope in the different areas of care. But technology in healthcare delivery is more than clinical applications. And what we need is some serious discussion on how value is being created through the deployment of this technology and how value is going to be captured by the different players in the deployment of this technology. And two issues that I want to focus on, that is, one, you need a holistic approach, and second is a multi-stakeholder perspective when you think about technology deployment. So what do I mean by holistic approach? Technology really is an enabler, but I would say that enablement does not guarantee a successful solution delivery. What do we need to consider? What problem are we trying to solve? Because if you start thinking about some of these gatherings, I've been to some of these now, you get people from clinical side, you have technology people, etc. So this is like, elephant being described by six blind men. Everybody looks at their own perspective and says, this is the problem. I think I know what the problem is. Who are you trying to solve this problem for? Because when you talk about technology delivery, is it you're trying to get to the patient or to the healthcare worker? Who are you trying to solve the problem for? How will this technology really help? And will technology deployment really lead to a satisfactory solutions? Just last month I was in Uttar Pradesh and I was visiting a clinic, and this was set up in partnership with a tertiary care hospital. The doctor in the clinic was given an electronic digital ECG device. So from a laptop you can do this and you can send it, transmit it to the base hospital and get some diagnosis done. And when I inquired from the doctor, he says, we don't use it anymore. I said, what happened? Did the technology fail? Is it a power issue? Because in rural areas this could be a problem. He says, no. Yes, we get the diagnosis, but none of the pharmacist stores here carry the drugs. So if I don't have the medication, what's the point in diagnosing a disease? So I think that's what I mean by taking the whole perspective. Just because I deployed a technology, diagnosis does not necessarily mean there will be care available. Then you have to take a multi-stakeholder perspective. And what I mean here really is, if you look at the whole healthcare delivery system, there are several stakeholders here. Obviously, there's a patient, and we can call them a customer. Customer, of course, is looking for better access to quality care. Then you have the service provider, typically a healthcare entity. And they may actually deploy technology for various reasons. One is, say in the case of telemedicine, expanding reach or expanding care into new geographies. Or it could be smart care. In a hospital, I'm getting all kinds of people traveling. Could I do more effective triage and get the right patients into the hospital and not have the unnecessary patients come to me? It could simply be to build a brand, or it could simply be a CSR activity. But the way the service provider views this matters in terms of how they will justify the deployment of technology. Then you could have potentially a platform provider. So the platform provider could be the healthcare entity itself, or it could be an independent channel partner. Now, for example, think about a kiosk in a telemedicine center. They could be using this to expand service offerings, because health is one of the service offerings compared, in addition to others, and therefore they may see spillover benefits from offering health on other products and services that they have. So that will kind of drive how they view this technology deployment. Then there's technology provider. There's a telecom company, perhaps, or hardware, software vendors, and for them this is a new source of revenue. Government plays a big role to fulfill its obligations to improve access to quality care, and there could be NGOs involved who are fulfilling their social mission. Now, if you look at all these different players, there are some issues that come up that need to be resolved. Who owns the customer? Is it the hospital or the healthcare provider? Is it the telecom provider, or is it the platform provider? These are three big entities that might come together to offer a solution. Who will orchestrate the network? And this is extremely important. Somebody has to be in a position to orchestrate the entire network. And what are the objectives of each stakeholder? And these objectives could mismatch. One provider is viewing it as a CSR, another is viewing it as a for-profit business. And there could be a clash coming in right there. Is there a broad alignment of objectives across these stakeholders? The reason I emphasize this is if you don't kind of think about these questions, that deployment may be a pilot but will never lead to any sustainable or scalable solutions. So based on my previous study of telemedicine deployment, there are some challenges. Some of the issues that I mentioned did come up. But in addition, there, of course, this was 4 years ago, still challenges of connectivity, logistics in terms of how telemedicine is going to be delivered, deployed, where in a hospital setting would it be? Is it in the doctor's office? Is it a separate telemedicine room? Fairly low utilization of the networks that were already deployed. Payment issues were still unresolved, and the cost of technology investments was still very high. I think 4 years hence, while some improvements have happened, I think several issues are still unresolved. And primarily when there is a partnership involved, deployment requires coordination between multiple stakeholders, and that has not been, I think, resolved satisfactorily. There are some new models on the horizon. There is World Health Partners in Uttar Pradesh that is deploying a telemedicine system. There is another initiative called e-health points in Punjab. It's too early to say how they will do. They have made some modifications to address some of the challenges I mentioned earlier. The other area is mHealth. So what about mHealth? Let me illustrate this using an example in a particular area of care. So if you look at tuberculosis, the biggest health crisis confronting India, in my opinion. And what are some of the challenges here? Fundamental challenge is lack of awareness among the patient population of what this disease is all about. And typically a rural patient or even an urban slum patient thinks it's a case of death. There's a huge social stigma attached to TB. And from a treatment perspective, the big challenge is it is a long gestation treatment. You need to take the medication for 6 months. So treatment compliance is a very big issue here. Now, if you think about the WHO recommended DOTS model, that requires a 3-tier network to deliver treatment. At the tier 1 level is the TB hospital. Tier 2 are the diagnostic centers, and Tier 3 ideally should be last mile solution, the treatment centers. Now in India, the first 2 tiers are actually fairly adequate. While resources at Tier 1, the hospital, and Tier 2s are adequate, last mile has been a challenge. Now, if you scan the horizon, there were some solutions proposed earlier. There was a startup coming out of MIT that said, well, it was a technological solutions. There is something called a U-box that can be filled with pills, and the patient will get a reminder system to say that they have missed a dosage and therefore they need to take a dosage. This didn't go very far. There were some pilots, but after that it was abandoned. And the main problem was treatment is more than simply a reminder system. For a TB drug treatment, there is counseling required and there's lots of hand-holding required to make sure that the patient actually goes through the complete treatment. So I've been looking at an NGO in New Delhi called Operation Asha, and they have been very successful in developing and deploying a robust delivery system. They are achieving treatment completion rates of upwards of 92-93% today. What they have done is they've deployed a network of treatment centers, so really populated the Tier 3. within walking distance to the patient, and they are staffed by a counselor and a provider, open from early morning till late night for convenience of the patients, and properly incentivized people, especially the counselor, for detection and treatment. So incentive mechanisms play an important role, and once you put an incentive mechanism, there has to be a monitoring system in place. So what they have deployed is a biometric and cell phone-based technology that allows them to monitor treatment and monitor the improved performance of the health workers. There are other examples. For example, SERP, an organization here in Andhra Pradesh, working in MCH, has deployed mobiles to health associates for data capture, monitoring using pictures, etc. Then they orchestrate the network in coming up with novel contracts with telecom companies. So you kind of think about this, there are two types of technology. One is technology for efficient healthcare delivery, and we've mentioned a couple of examples here. In these settings, it is easier to justify value because it's an efficient delivery mechanism. There are fascinating new innovations coming up on the horizon, mostly for diagnosis, but like the problem I talked about in the ECG case, diagnosis is only first step. You need to think about the whole delivery mechanism. So in conclusion, you need to take a holistic and multi-stakeholder perspective in delivering solutions. I think a big role that some of these technologies, especially mobile, will play is in the non-clinical part of the value chain. It is improving efficiency, effectiveness of the healthcare worker in delivering the health services. And adoption of new diagnostic technologies may require really thinking about new business models for the reasons that I talked about earlier. Thank you so much. We'll take questions towards the end.
Thank you, Professor Ravi, and indeed it was an extraordinary presentation. A person like me comes from a Tier 2 city, and I work in a large hospital, maybe 800 beds, and I can understand the problems we have in the hospital connecting to the urban centers and the rural centers, the connectivity problems and things like that. But yet, things have improved a lot all over the world and also in India. Today, we are able to connect to our patients, maybe a patient in Tirupur, a patient in Gopchittipalayam through the mobile. We do the tests by about 7 o'clock, and by 7:30 when he is in Tirupur, the result is on his cell. So that way a lot of things have happened, and let us again discuss about your presentation during the question and answer session. Thank you very much, Professor Ravi again. Now may I request Dr. Prabhu, a medical doctor by training. He worked in intensive medicine for 9 years. Health informatics is a specialization from UK, and he is now working for General Electric for the past 5 years. I've known him as an excellent engineer, as an implementer. In fact, he implemented the PAC system in the hospital, in our hospital. Before I request him to come out to the podium, may I request the audience, the organizers, to do something about the echo we have in the hall. We are not able to hear the speaker clearly. Go ahead.
Thank you, Mr. Anant Padmanabhan. Morning, everybody. I think the audience is picking up slowly from what we started with, and we are running behind on schedule, so let me get started. I'll be talking on successfully implementing healthcare IT as I see it from a health informatician's perspective. And as Professor Anant Padmanabhan introduced, I am working for GE Healthcare IT as the Director for India. This is the agenda I am following, healthcare IT. Why it's different from other IT implementations? It tends to be domain intensive, and those who have gone through a couple of cycles of healthcare IT implementation will agree with me on that. Change management is very key here because we are dealing with healthcare workers, doctors, nurses, and if you are asking them to do things in a different way, you have to have a very good reason for that. Interoperability, a key issue. Countries which have gone before us, the US, UK, Australia, European countries, built systems over 40, 50 years, and today we are left with systems which are in silos which can't talk to each other. So we have an opportunity here to learn from those mistakes and build systems which can talk right from the beginning, because it's clear that systems have to talk to each other. Some of the benefits which studies are showing: government initiatives in India, and I'll summarize with transforming healthcare with IT. What are the different ways in which this is happening and can happen? So what do I mean by this? Collaboration is key to success here, because everybody has a part to play. The government, industry, payers, providers, and the patient stands to benefit from this collaboration. Sadly, this is something which everybody talks about, but how much of this is actually happening? These are the forums which actually give us the opportunity to bring everybody together. Today, we are starting this conference, and today and tomorrow, if you look at the list of people who are here, this is the platform which helps people to come together and understand the issues which each other face when we go for such an implementation. Some lessons which we can learn from others, I've just picked a few. In the US, they're spending a lot of money now. Obama's ARA funding and the High-Tech Act which has come in. But there are ifs and buts. Studies which are going on are saying that, is it worth spending so much money? Do we get all the benefits that is being promised? UK, I was in the UK, I was part of this national program for IT. And as you all know, the work that Tony Blair started, it has achieved some things, but there is a whole lot of things which it couldn't achieve. And a beginning was made, a lot of money was spent, but there are key lessons for others who are trying to do similar things, where we are talking about countrywide healthcare IT. This is a HIMSS Healthcare IT Maturity Model presentation. What it shows is more and more hospitals, more and more vendors are moving, adopting healthcare IT, and from bottom to top, level 1 to level 7, it just shows how it evolves out, one out of the other. So more and more people are getting into it, and they are evolving. As they start using, they are moving into stage 1, stage 2, stage 3, and stage 7. And this is what Gartner says, that today we are at a point where it is like a helper model, healthcare IT. So the evolution is, initially it is a collector of data, then it becomes a documenter, then it becomes a helper, and in future it can become a colleague, and finally a mentor also, with self-learning networks and the possibility of having these things at the point of care, at the point of diagnosis. Some facts randomly picked up. Healthcare is reactive. So a problem happens and then we react. Preventive medicine is happening, but it's not that much. We are talking more about treating people, and it's not directly a medical product. So clinicians really don't buy into it. It is considered an administrative thing, a billing thing, which is not the case. More and more clinically intense applications are coming in now, and so this is something which needs to change. And the adoption of EHR, EMR is often piecemeal. This has been the experience in the Western countries. So they start with the billing, and then the clinical values, and then the lab, then the radiology, and then you end up with this scenario where I told you, you have 6 different systems, but they don't talk to each other. So how does that translate to a patient? He has to re-register in every department, and the data cannot move from one department to another. Now, this among health informaticians is a hot topic. How do you do a customer implementation? Do you go big bang? You take all the requirements and take the whole hospital and go and implement the software? Or do you do it in a phased manner? Evolve one by one. So there are good and bad in doing both. But for a country like India, where healthcare IT is still at a very nascent stage, what we are seeing is most of the places where systems are getting used, the billing and the administrative part is existing. So the ADT happens, then the PACS risk happens, the workflows are quite straightforward, then the lab, pharmacy, and finally the CPOE, which is computerized physician order entry. What is grouped as advanced, the clinical documentation part, flow sheets, which are trackers for data which is used in the ICUs and in the intensive care units, medical notes, which can be free text or templated. You have mixed model notes, progress notes, discharge summary. These tend to be more complicated and the workflows are not very straightforward. So these appear to be better off once the hospital or the organization is comfortable getting the healthcare IT. And very important, as in all IT projects, project managers are expected to complete projects on time, within budget products. We have this concept of scope creep. So as initially the customer doesn't know what possibilities are there in healthcare IT, but once he starts learning, then the number of things that he wants the system to do increases, and it becomes a never-ending game of more and more features getting added. So this is described as scope creep, and it has to be managed because the requirements has to be gathered as best as possible in the beginning, so projects can be completed on time and within budget. Sharing success stories. This is a no-brainer because we hear a lot of flack from the press globally. I'm sure you would have heard of the disasters that they talk, which the NHS went through when they tried to adopt healthcare IT, and the US huge spending which is coming in, the ifs and buts which people are talking about. So it's not that there are no success stories. There are success stories. This is one example of a success story, and such success stories need to be shared widely so people actually know that this also can work. This is a nice slide which shows that it is only an enabler. IT is only an enabler. It's not a solution for all the problems which exist in the healthcare industry. Unfortunately, that expectation is, if it is there, it is bound for failure because it can only be an enabler for the process change. And these are the three key parts of it: people, process, technology. All of them are important, and healthcare IT will succeed if these three things are taken care of. Now, the bottom, what I have put there, clinical leadership essential, is very important because, after all, healthcare is led by clinicians from the front, be it doctors, nurses, pharmacists, whoever. Each one is a leader in his own domain. And so the change acceleration process is a change management technique where the end users are actually shown how that the change is actually benefiting them. And this is a training which is given to them, and some of the barriers which have been reported and which are known as cost, and these things need to be discussed, explained, and the end users need to have a buy-in into the implementation. Because if that is not there, again, this is bound for failure. And we are really not the first industry to go. There are best practices in other industries. If you take the banking, finance, or the travel industry, these are like simple examples because the workflows there are quite simple. Complex, aviation, nuclear, space, these tend to be complicated, but processes are there and we could learn from them. Interoperability, one slide, all of them provide electricity, but look at how many different ways it comes in. And we all know when you're traveling, you need to carry adapters to connect to different systems. Systems interoperability, as I mentioned, you concentrate on transport, content, vocabulary. These are the three key areas in which focus has to be there. And I'll quickly run through the benefits. I think we have gone beyond time. I see the red bulb there. Key benefits, some of them I've summarized, and these are some studies which we have done. Some government initiatives. In Andhra, we have the Arogyashri program, very successful. You'll be hearing about the Arogyashri program tomorrow from Mr. Babu, who is the CEO. Kalangar Kapiti Thittam in Tamil Nadu, again a health insurance project which is run, a lot of IT is used. The Rashtriya Swasthya Bima Yojana at the central government, IHIND, Indian Health Information Network Development, the UID project, the government of India is supporting all these initiatives. They have come in with these policy initiatives, and this is the IHIND plan, a nationwide network where data could get shared. There are three components to it. The health information network is very much working, and the health secretary formed a EMR standards committee these are some of the standards which have been proposed, and we will be wrapping up in a couple of weeks with these standards. And so the central government would be bringing this into India. So I think I'll end my talk with that, and thank you very much for this opportunity.
Thank you, Dr. Prabhu. I think Dr. Prabhu very rightly focused on the implementation of EMR in India and the difficulties we have. No doubt EMR implementation has seen its beginning in India, but we have our own problems, and I think he says that we need to increase the pace at which we are implementing the EMR. He also focused on the point that IT projects have to stick to the time, and IT projects have to stick to their budgets. And he also pointed out a few projects like Kalanja Kapitadittam and Arogashri, and they have been doing extremely well. As he said that we need to stick to the time, I think we need to stick to the time in the program also, and we are already behind schedule. A note has already come to me from the organizers, so I request the subsequent speakers to cut their time, and maybe I'll be a little rude in calling them after about 5 minutes. Please forgive me for that, and we will have just about 5 minutes presentation for the rest of them. May I now request Professor Ganesh Natarajan, the chairman of ITCII and the CEO of Zinza Technologies. He is a PhD in knowledge management, and he is going to talk to us now.
Thank you very much, and very good morning to all of you. I'll just take very few minutes more to enlarge the agenda, because you've already heard some excellent examples of success, as well as what technology can do, and I'm sure my friends from IBM will talk a little more about that. What we're trying to do in CII is really saying that, today morning there was an item in the newspaper talking about that there cannot be two Indias anymore. We're all very proud of the elitist India that grows at 9.5% or whatever, but we keep forgetting that there is a huge India out there, which is called Bharat, which needs the same support, the same access to education, access to healthcare. And what we have tried to do in CII in the last 2 years is really take what we call an inclusive IT agenda. And what I'm going to talk about here, obviously, is how that works for healthcare. And one experiment that we're currently doing with a lot of help from Sangeeta Reddy of Apollo to see how we can take a successful experiment which integrates healthcare education, healthcare governance, and of course, telemedicine and other initiatives in one small town. So let me just start with, this is the obvious one, which I won't spend time on. I think we all know that there is a problem of inclusion, that we just aren't able to reach out to enough people with better healthcare solutions. We also know there's a massive gap in demand and supply, because I think the statistics, the data that we see is all pathetic as far as the country is concerned. And there is a lack of analysis. We just don't have, except in a few governments, real slicing and dicing of data where we can come up with some serious suggestions on how to take that forward. So the net result is, I think, regular models of delivery. We're already late in the game. It's almost like this session. And there's no way traditional methods can get us to the finishing line. So I think that's really what we're talking about. If you look at the supply and demand, I think one problem we are seeing obviously is availability of doctors. Much more in urban areas. The best quality of healthcare is available more in the urban areas. The interesting part is, and I was telling somebody that we had a meeting with the Ministry of IT, Government of India. They have enormous budgets. It's not like there is no budget available for ICT deployment. In fact, the service centers that you have, the CSC project, which already has 1 lakh CSCs rolled out, there is enough infrastructure available for information kiosks, for access to the people at large. I think the real problem we are facing is, how do we get better applications or better usage of these CSCs on one hand, and how do we connect them to the medical practitioners, the providers, the hospitals on the other side. So I think that's really what we're talking about here. And I think what we're really talking about is, how do we innovate and make healthcare available to all. So I'll quickly move to a picture of what we're trying to do here. This is in the city of Pune, where we are trying to rope in, as I said, healthcare providers, which you see on the top left-hand side. The CSCs, which you see at the bottom, this is the common service centers, which are available in abundance, to my mind, horribly underutilized, because there's hardly a 20% utilization. And when you expect an entrepreneur to run a CSC, he finds it extremely difficult because of lack of applications. And on the other hand, there's this cloud of requirements, which you cannot see from there, but I'll just explain this to you, which is how government data is analyzed, how can, for instance, the crying need of the hour is, how do we train not doctors, but nurses, more bedside assistants? Because if you go to any hospital in this country, I think we're finding that the biggest challenge is getting people to do basic tasks of healthcare. So how do you provide that education is a very fundamental level, and telemedicine and other diagnostic procedures. So I think what we're trying to do here, and I won't dwell upon this, is to take all the technology capabilities, the applications that are available, not just in India or abroad, but bring best of breed through a project that we call Pune Connect, which will enable education, healthcare, and access to data for all providers and all people who require it in the ecosystem. So basically what we're saying is the potential of connecting up common service centers or information kiosks, all the experiments that are in place across the country is enormous. We can standardize services. We can have one-point access, whether it is to information, education, or healthcare access. As I mentioned earlier, we can have data of standardized services available so that people know how they can avail of whether it's diagnostics or simple medical solutions. We can have self-sustainable communities where people are helping each other. It's really a self-service model where they can work with each other and the providers to make that happen. And last but not the least, how do we connect up the CSCs? The best practices that you just heard, whether it's in Tamil Nadu or Karnataka or Andhra Pradesh, how can that go into Uttar Pradesh or Madhya Pradesh, etc.? So eventually, we have a national program that connects up and makes this important and available to all. And finally, I think what we're saying is that when you look at ICT, and I'm a great believer of the fact that there is a plethora of IT solutions available. The real challenge is, how do you take commonly available technology and use it uncommonly well? Because the more jargons we use as ICT practitioners, the less it connects or the less it gets through to people. So I think a simple 4-point agenda, and I hope as we go along in the next 2 days of this conference, we'll keep debating this as we go along, is first is service delivery transformation, which you've already heard about, that there are multiple experiments, as the 3 speakers before me talked about, and how do you take that to transform service delivery? Transformation in research, I think some of the richest case studies of diagnosis and problems are in Asia and Africa and not so much in the Western world. So how do we ensure that the learnings filter through to future diagnostics? Transformation in medical education, I stressed on that. I mean, we've been very successful in the skills experiments around the country, and that's really taking off, and I think the same thing should happen in education. And finally, transformation in growth. As we build, and coming back to my original point, as we build a truly inclusive India, if we can bring not the creamy layer of 100 million people, but maybe 1 billion people above the poverty line and actually make healthcare and education available to all, how can ICT make the difference? And I hope as we go along, we will hear more about this as we go along. Thank you very much, and thanks.
Thank you, Mr. Ganesh Natarajan. It was indeed a very nice presentation. I think he very nicely brought out the need for standardizing the health e-services in the country and consolidating the data. And he also talked about a very innovative concept, pay-per-use. People like us in large hospitals located in the semi-urban areas, maybe a large hospital, maybe 800 beds to 900 beds, we do about 20,000 transactions a day. 20,000 transactions a day in a hospital. And I'm just trying to find out how we can pay per use. I think it's a very interesting model. I think we should talk more about it, understand more about it, and see how we can use it. And he also spoke about the the power of the M-Health. We have seen it again in the rural areas in the country, and I'm sure this will go further in the years to come. Now I have Dr. S.G. Sendilvel. He is from IBM Software India. He is an SME and solution leader, healthcare and life sciences. He is going to talk to us on healthcare 2.0. I think it's a very interesting concept. People like us have been very used to having individual silos of IT computerization in the hospitals. I think 2.2 will do a wonder. Let's see, you have something more to say apart from 2.0. Thank you.
Thanks, sir. I'm audible? Yeah. Okay. Sorry about that. Healthcare 2.0, in fact, the fashion today is everything is 2.0. It's like Web 2.0, Travel 2.0, and almost everything is. So there is no wonder why we cannot have healthcare to have a 2.0. The difference is in IBM we believe, and healthcare is one of our priority industry where we do a lot of innovations. What moved us from the traditional healthcare, which is paper-based, then into the smarter healthcare or smart healthcare, which is relatively IT-enabled, moving into a smarter healthcare as part of our Smarter Planet themes is Healthcare 2.0, where the primary agenda has nothing to do with the hospitals, it has nothing to do with the payers, it's all about the patient. How do we make life simpler, easier, and better for the patients? Right? So it's a consumer-centric focus. So that's what it brings in. So when we say a smarter healthcare, which is what I mentioned earlier, it's about forging a partnership between all the stakeholders of the healthcare delivery network or healthcare delivery facilities and bringing the information together in a way that whatever is the decision which is made with respect to the clinical part of it has a solid scientific background, right? So you would have been bored to death if you have not seen this. So this is about the entire Smarter Planet theme is about instrument everything possible, that is as much data collected would make life easier, interconnect all of them so that in a way that this information can talk to each other to bring in a meaningful use, intelligent enough so that it actually gives you the gist of information in the ocean of data. Okay. So in the Smarter Planet, most of the healthcare organizations are expected to transform. I would come back in a sec as to why it has to be. Is higher clinical efficiency is warranted, improved patient outcomes. In fact, my previous speaker was already mentioning about that why is there a pressure to increase the outcome or pay for performance rather than pay as a service being billed for. And there is always a pressure, do more with less. So lower the operational costs. Effective regulatory compliance, which is essentially is what lack in this part of the world, and it keeps evolving. So we are around the corner to have all these compliances coming in. But then, where do we move from here of instrumented, interconnected, and intelligent systems into healthcare which is more patient-centric and everything else remains secondary? Is one is because of the value for money. There is no industry today which can actually live in their what is called as ivory towers and say that no, this is what I offer, whether you like it, you take it, or you don't take it. That days are gone. I mean, even healthcare industry, as we always keep saying, and in the medical community, we keep cribbing about it, that it is becoming a consumer industry. People have started asking for services and service delivery, a price against the services delivery, right? What happens is monitoring quality and patient safety, scrutiny by the public, by the individual, and by the organizations have become very, very stringent. Increasing consumer responsibility. So the patient actually does not take a decision today. I don't think so there's anyone who take a decision where the healthcare cost or the expense involved in delivering or getting the cost is slightly higher than a consulting fees. So if you have to spend anything more than 10 to 20,000 rupees, there is always a second opinion, third opinion, and fourth opinion. There's always used to be a joke. The largest or the oldest and largest practiced profession seems to be healthcare. For all reasons, if you cough or your neighbor coughs now, either you or your neighbor would immediately jump in and you say, you must have had cold water in the morning. You are actually providing a consultancy, a healthcare service there, right? In a scenario like that, where the consumer has become more and more aware and he can move forward to get more informed information or informed judgment by connecting with multiple people, how do you increase your outcome? How do I actually deliver all this in the current given scenario is a patient-centered care, and while delivering this patient-centered care, can I measure the value of it? Can I quantify that this is what I actually offer? And by implementing certain systems and processes and policies, whether each one of these systems can quantify the results on that. It's not only that the patient has walked in and you set up a whole system and then he walked out with that, right? Yeah, sure, absolutely. So this is the information which I was actually talking about. If you look at it, traditionally, the clinical data which is available for a physician to make a decision is typically in the range of 5 to 10 parameters on top of his mind or right in front of his charts, and it is based on these that his transactional decisions are being made. I'm not talking about while you are admitting a patient, but an ongoing case, right? But what has happened is now with all the genetics and SNPs, haplotypes coming in, then you have decision with respect to multiple chronic cases where you have an interconnected or interconnected and multidisciplinary care to be provided, and functional genetics with gene expression analytics. If you look at it from 2000 to 2010, already we are on the logarithmic space. In a few years now, we would have even proteomics data coming in, which will have a direct impact on how do we actually deliver care in cognizance with all these available information. Can a single physician at the point of care remember or do that decision making in no time? Right? So this is the approach which we recommend, and the approach is starting from the bottom. It's intermediate electronic medical records. We are not even saying that we are talking about an electronic medical record because there isn't any system which is actually comprehensively exists today. So you have some system. Even if you don't have any system, you can actually have your paper documents being scanned and then archived and pushed in forward. From there, you get into an integrated a view, which we call them as glass layer, which is the healthcare portals, whether the clinician uses or the patient uses it for. Then the next one, which is not applicable yet in this part of the world, is information exchanges. Like our telephone exchanges, there are multiple networks of facilities, whether it's government, private, or others. How do you connect in a way that seamlessly a patient carries an information in a card? If I have to take an example of a health card, like my bank ATM, today I can carry my ATM anywhere in the world. I still get whatever I wanted to do. Is there a day, or are we moving towards that, where I can carry my health card similar to my ATM bank card, a financial transaction card, and I still can be rest assured that I will be taken care of wherever I am in, right? Next, moving up in the value chain becomes healthcare analytics. There's a lot to be said, a lot being discussed on that, and finally, an advanced clinical decision support system. The primary agenda of advanced clinical decision support system is not to replace the physicians. It is to enable them to drill down and to help them or assist them in analyzing this thousands and thousands of information which are available, right? I would skip it through because this is where the patients are expecting today, and this is the area. So that's the curvature path through which we need to be getting in, digitize all the clinical information so that immaterial of whether you are a super specialty or you are a single specialty or you are a primary physician, you are in a position to do that. View and exchange the information, derive value out of intelligence from improved care quality, and deliver clinical patient and patient information to enable patient-centric care. Each and every one of these components are technology driven, and there are various levels at which the technologies can actually come into the picture. And it basically is a journey. It's not a silver bullet where you can actually shoot it and everything else is in place. It takes some time, or a period of time is what we aim to achieve that. Why do we do? It delivers 4 different types of value. One is the strategic value, which is about ability to move forward and agility. Operational value, which is what traditionally everybody has been talking about as reducing cost and improving resource utilization and all of them. The brand value, and finally the societal value, why do we say that? Everyone in Danish are pretty happy because they have a national e-health portal. You move around anywhere in Denmark, you still be able to carry that single card and get that information out. You don't have to really worry about it. So that's the mindset, the societal value which we get in there, right? And this is what I would like to leave you with. Typically, what happens is every IT system which is not adopted into the hospital is because of this. We think that bringing in a smart ID guy who would do the technology with the doctor, which is essentially is oil and water, without a suspension in place. Thank you.
I think he said you first digitize your information and derive value out of it, and then we should deliver that information in a way the patient experience is better. I think it was a very nice presentation, and I want to tell you, Mr. Sendal, that in a hospital like ours, we use smart cards even for transporting patients in the hospital. By just using smart cards, using barcodes, we have eliminated about 500 phone calls a day. I think that's a great deal. Okay, thank you, Mr. Sendalvel. May I now request the last speaker, Mr. Naveen, leads the enterprise asset management business at IBM, India, and also South Asia. He is a mechanical engineer by qualification and also has done his post-graduation in management from XLR at Jamshedpur. He is going to talk to us on optimum utilization of facilities in a healthcare setting. There you go.
Good morning, everyone.
But you will remember the time, 5 minutes.
Okay. So like Mr. Natarajan was saying that today in India we are facing a challenge of, we have a big gap of doctors. Another is the hospital beds. Typically what it means that we don't have enough facilities across the country. So we have lacking infrastructure of hospitals. In hospitals, if you go, you don't have enough beds. Even if you have beds, perhaps you don't have equipments like X-ray machines, the other testing equipments. So what's the solution? Whether we should buy more and more? Do we have the money for that? Or shall we try to optimize what we have? So that's what I'm trying to capture in a short 5 minutes today, that where IBM can help you and where this smarter healthcare initiative like Dr. Senthil was talking about, one of the core piece of that is asset management space. So typically, what is the traditional business value driver of a healthcare provider, whether it's a government hospital or a private hospital? They have to provide a high quality health patient care with an improved clinical outcome. So when you are providing healthcare, you need to your patient to be happy and healthy. At the same time, you want to ensure all the compliances, whether it's a government compliances or medical compliances, you want to comply with all those, that you should not be in a problem tomorrow. At the same time, today with technological advancements, you have a lot of equipments which are much technological intensive than what it was 30, 40 years ago. So you have to manage that. It can be clinical biomed, then you have facilities and engineering, you have imaging system, you have EHR system, and obviously now the IT infrastructure is pervasive. Any organization cannot live without that. So in fact, I was reading somewhere that today in operations theater, doctor also want to consult people in the other countries or other doctors. That is the kind of IT or the networking has come in the picture. At the same time, the hospital administrations are looking to reduce the cost of providing these services. How to manage at a minimum cost. Now, just to give you an idea what is the facility, what it can be. So just a picture of an operation theater. You can see that how complex today it looks like. It looks like perhaps something similar to NASA control room. Okay, perhaps it may be more complex because it also involves human decision making. Now, with this asset, this kind of complex asset, what is the problem you have? Whether your assets are visual, what is the kind of staff you have, what they are doing. So like doctor was saying, that by implementing a simple barcode, they were able to reduce 500 tickets or 500 requests. Can we automate that? Yes, IBM can help you automating that. So similarly, over procurement of mobile assets, you have a stretcher which may be lying somewhere, you don't know, and you end up buying more. You have whatever consumable items or whatever, you don't know what is the level I have, and you end up having a high level of safety stock, which actually means money invested in the inventory. Excessive charges for rental equipment. You had to have 5 machines, equipments, and you ended up hiring 10. You are paying for them. And at the end of the day, you are billing it to the your patient. Asset damage or loss. When you don't have visibility, it is lying somewhere, it is getting damaged, you don't have any control on that. Lost and misplaced equipment. A patient was released, then perhaps a wheelchair is put somewhere, someone took it to the car parking, you don't know where exactly it is and who took it. So the accountability comes in the picture there. Now this is the cost part, how it affects your operational efficiency. A patient walks in your hospital, he gets admitted, and he is a very critical guy. And you are now looking for where is my X-ray machine, portable X-ray machine. How you will find that? Where in the hospital? You cannot have 1,000 portable X-ray machine in a 500-bed hospital. So these will be the challenges where you are actually affecting your operational efficiency. Then what happens? There will be multiple departments. Some department will hoard it. They will get 10, 20 allocated to their department, and other departments maybe even if they require it for critical purpose, they are not able to get it. So it is affecting the efficiency, it is affecting the cost there. And obviously, when you don't have visibility about your assets, your staff, what they are doing, it will be giving you problems in complying to your audit, doing a validation, and the procedures, because you have to search for the data across the hospital and put it in a system so that you are complying to the regulations. Now, even if you are having a little visibility, is it going to be optimally utilized? Is what it can do, is it doing? So that's where optimal performance comes in the picture. Now, what IBM recommends, we should shift from compliance documentation to operational excellence model with an integrated asset management. So there are 3 words here: compliance documentation, operational excellence, and integrated asset management. So compliance documentation should not be like a forceful thing. It's not like a problem with healthcare. I have seen it happening in metals. I have seen it happening in oil and gas industry. So people do the work, then come and fill up the forms. Is it the way it should be? Is this mean for that way? This regulation? No. It's mean that how you are doing your work, which is helping you to perhaps increase your quality of the job. So it should be automatically done, and that's where the system will help you. Then operational excellence, that too without sacrificing the regulations and the job, perhaps not hampering your day-to-day work. Then today asset, like I was talking about, it has blurred. Earlier it was like a 2 classified, IT assets and non-IT assets. Today there is a big development in that space, and many of the non-IT assets have become an intelligent asset. So the boundary between an IT asset and a non-IT asset has blurred. At the same time, you are using those assets to provide facility. So how to manage this complex mix of assets on a single platform? You cannot have a system for the IT asset, then you have a system for non-IT asset, and then for a ticket purpose or help desk purpose, you are having another system. Then actually you have to put another IT team, which may be perhaps costing you something like your 5-10 doctors to put a system like this. So better to have one system, perhaps with a minimal expenses, what you want to achieve. Now, I was talking about the asset getting lost. You are not having any visibility, how to find that. There comes this real-time asset locator technology. A lot of sensors technology are today there, and IBM has integrated this with our asset management solution, that how you control those equipments, how you know the history of those equipments and their locations, and who booked it, the accountability of those equipments. So that's where this real-time asset locator comes in the picture. Now, this is the solution what I'm talking about. And in fact, the leading hospital in India, perhaps it's quite obvious, they are using this system. And they have the asset management. This product called Maximo has asset management, which actually defines your all asset classes in one model. Then you have work management model, where you do your work, you assign the assets to someone, you do a maintenance work on that. Then you have procurement management, complete procurement management model there. Materials management model, then actually inventory management model. You have a contract management model here, which is like your master contract, lease contracts, all those contracts, purchase contracts, it can take care of. Service management, very important. You can raise a service request where it is like right now, whether it's approved. And it is also giving a platform for the asset owners, the managers, and providers to see what is happening, what are the SLAs for that asset, whether it is meeting that. Many times you are taking on contract or outsourcing it from someone. Okay, so what is the SLA for that? Whether I am able to use that, whether it is able to meet the SLAs defined when I was procuring that. And then this system is on a JT platform, which essentially means it's a web-based technology. Anywhere in the world, you install it, and you can access it from anywhere in the world, till the time you have the access to that server. It's a standard base. We have a lot of standards for healthcare service providers, and it's a SOA-enabled. So if you have any system, in-house system, or a standard any other system, it can be integrated to that. And then comes the real-time asset locator, which in conjunction with the Maximo provides the location of the assets, give you handle how to optimize the user of the asset, like visibility of the mobile equipments, reducing the loss of the assets. So this is how the solution will be built, and perhaps we can meet sometime and we can discuss further in this detail because of the scarcity of time. Okay. Thank you.
Thank you, Naveen, and it was a good thank you slide, really. He spoke about the assess management, and particularly in the operation theaters. The operation theaters have dramatically changed in the last 5 years. Not only managing the assets in the operation theater, but the way we really use them. Now we are talking about integrated wars, where the ICT application plays a great role in the operation theaters. Whether you want to control the laparoscopy equipment, or you want to control the operating theater lights, tables, pendants, whatever. I think the ultimate in ICT in the operation theater room is already out, and some of the hospitals in India and many of the hospitals in US have been using it. I think he was trying to drive at that point, and he was also talking about the portal-based healthcare. In my opinion, maybe in another 4 or 5 years' time, mobile health, portal-based services in the hospitals will become very, very prominent, and you will see them being used. Somewhere down the line, he also spoke about facilities engineering. Today, in large hospitals, when you have a floor space of about 10 lakh square feet, it's extremely difficult to manage all the air conditioning plants, maybe the generating sets, boilers and all that, physically sending the technicians and engineers there. So BMS and all that is now playing a very, very important role. Thank you, Naveen, for your extraordinary presentation. And we just have about 5 minutes. So we'll take a couple of questions, and we'll see what we can. Can I have the lights on, please? Can we have the lights on?
Any questions? We just have 5 minutes for the Q&A session.
There's one gentleman there. Can we give him the mic, please? Go ahead. Go ahead. Louder, please. Slowly. There is an echo. We are not able to hear you. Go ahead. We are not able to comprehend your question. Maybe you have to keep your mic a little lower.
HIPAA regulations.
HIPAA regulations.
All right. Can you hear me? Hello?
Can we have the sound of the mic, please?
So the way this clinic works is that if a patient calls into the doctor's office and says they want an appointment, the secretary will offer them the choice of coming to the group clinic. And if they're going to come to the group clinic, then they do need to sign a form basically saying that they're okay with their appointment being done in public with others. So that's the way it's being done. It is not forced on any patient. It's a choice thing, and patients who are interested in doing it go in for that kind of clinic. Does that answer your question?
Next question.
I've got a question to the last speaker. He's mechanical engineering and MBA and equally the same category. Optimizing the services and the equipment assets. There was a beautiful report 30 years ago by Tandem Committee. The inventory is very important, and 30% of the current assets go into the inventory. Unless it is optimized properly, the organizations will lose heavily. That was a wonderful thing brought out, but the only thing is, my question is it related to the wonderful report by Tandem Committee 30 years ago? That is not.
Can you repeat your question?
There was a beautiful report by Tandem Committee 30 years ago that is not still implemented in this country about the inventory optimization. You talked about inventory management. That is wonderful concept you have really eulogized, but at the same time my question is, did you dwell upon a Tandem Committee report?
No, I don't have idea about that.
Kindly look into that. That was a wonderful research done, and that is not implemented in this country anywhere. And you have brought out beautifully relating to medical care.
What does it say? What does it say with reference to ICT?
That is only to say that inventory is such a wonderful concept. Unless you optimize, you will lose heavily. And in this country, inventory is not taken care of, though it is really reflecting on the kind of efficiency with which you are able to organize anything anywhere.
Let me just add one point here about inventories, particularly in the hospitals in India. Today, hospital materials management has gone a long way, and today we have portals in the hospital where the suppliers can access our portal. They can access the inventory, our inventories in the hospital, and they can make supplies, and payments are all made through the supply chain management. It is as good as any automobile industry or any engineering industry, believe me so. We are not holding high inventories. We are not holding 2 months inventories, 3 months inventories. We are hardly operating at about 7 days inventory for A-type items, 15 days inventory for B-type, and C-type it is about 30. Sometimes we can just get it as we want it, like it happens in a Toyota factory.
That is terrific, but at the same time the speaker himself told that there are 1,000 equipment for 500 bed hospital.
I think there are two issues. One is about the consumables and another is about the equipment.
No, the mobile assets he was talking about, 1,000 mobile equipment for 500 beds.
True.
Is it not over inventory?
No, not at all. No, believe me, there are many more equipment. In one ICU with about, say, 15 beds, we have 15 ventilators. If I have 100 ICU beds in my hospital, I need to have 100 ventilators sometimes. So I think
I am not asking the chairman. I am asking only the speaker, last speaker, because 1,000 related to 500 beds. My question is with reference to the speaker.
I think
No, you can talk on the speaker.
Yeah, you can talk from there.
1,000 beds related to 500 beds. What was your question?
Yes, there is 1,000 mobile equipment
Yeah.
related to 500 beds.
Yeah, so I was not giving like a ratio that 500 beds is 1,000 equipments. But at the same time, let's say you have a 500 bed, let's take a scenario, and you have, let's say, 50 these wheelchairs. Now, 50 wheelchairs, then you may be having 10 different departments. And when you are taking one wheelchair and just leaving it there, and you keep it doing, let's say, over 2 days, you're out of 50, 40 will be lying in one area. How you are identifying and distributing it across the different departments? How you will find that where my wheelchairs are? Let's say I take a wheelchair and take it to car parking. Now it's lying there. Whose responsibility is that to bring it back? And when there is a patient coming to my hospital, he is not able to walk, and I am just looking around for that wheelchair. So that is the problem you have to solve. That whenever there is a patient and he needs you as a doctor or a nurse needs that mobile asset, it should be available and you can find it within very feasible time.
Thank you, Navin. Thank you so much. I think you should spend some more time with him after the meeting.
Sure.
Okay, thank you so much. Thanks for the speakers, and we'll meet again. Okay.
Thank you all for the first session. But now, ladies and gentlemen, I'd request the chairpersons, Dr. Ganesh Natarajan and Dr. UK Anant Padmanabhan, to present the panel of speakers with the mementos. I request the panel of speakers to kindly be on the dais. Yes. Can we have a round of applause, ladies and gentlemen?
It's now my pleasure to request Dr. Ramswamy, Secretary, Government of India, Department of Science and Technology, to kindly hand over the memento to the chairpersons. Dr. Ananta Padmanabhan, could you please? And also to Dr. Ganesh Natarajan. Thank you very much. We are running a little short of time, and may I please request the next session